Hi, I'm Molly MacDonald, a breast cancer survivor of about 20 years and co-founder and CEO of Pink Fund, a national charity that provides limited but essential financial assistance to women and men in active treatment for breast cancer. And I'm a huge fan of our guest today. Ever since I experienced financial toxicity and started following Dr. Fumiko Chino and her studies, not only that, I really love her glasses and wardrobe. So I want to tell you a little bit about Dr. Chino. She is a medical doctor, a fellow of the American Society of Clinical Oncology, and a cancer researcher. She is the associate professor in breast radiation oncology at MD Anderson Cancer Center and the founding lead of the Affordability Working Group at Memorial Sloan Kettering. She is also one of the directors of the Cost of Care Group, an NGO working group to improve affordability in healthcare. And her research is focused on patient-centered care, including the financial toxicity of cancer care and survivorship, healthcare disparities, equity, and access. Welcome, Dr. Chino.
I appreciate being here.
So I know you've spoken and written. At one time I said, I think you were doing 52 papers a year about financial toxicity. And I can't even begin to tell you what a thrill it was to sit on a panel with you and Dr. Inu Alexandru and Dr. Booth at the FASCO conference. That was a real career high for me. So advocates, I hope you can watch that video from ASCO. We'll probably be able to have a link for that. And as discussed, at ASCO, recognition of this valid side effect of cancer treatment by practitioners and researchers is relatively new. So I've heard it described financial toxicity as possibly being like a grade 4 side effect of cancer. But to go back to the future, so to speak, how did this even become something that people considered? How did it get started and who coined the term?
Good question. I think that one thing to always highlight when we talk about financial toxicity research and action is that the concept of financial toxicity is relatively new. It's really just been in the last decade that people have labeled this term, have been popularizing it, and have been doing active research in this space. And a lot of the research that exists to date has been really descriptive, i.e., people have affordability gaps and it's causing harm. And we're moving into the future space now of how do we, try to fix it? What are the interventions? But the initial concept of financial toxicity arose because people were realizing that care was unaffordable. And I think that is a pretty straightforward thing, which is, when you can't afford your medications, care is unaffordable. When you can't get the proper diagnosis and treatment, care is unaffordable. And the concept sort of emerged in the early 2000s as something that we should probably try to study and categorize a bit more in depth. The term financial toxicity was really popularized by Dr. Yusuf Safar, who is my mentor at Duke. And he had a manuscript in 2010 that really outlined the problem. And the phrase financial toxicity is a little controversial because some people don't like it. They're like, oh, toxicity sounds like it's unavoidable, whereas this is unavoidable. And I like it because I think it sort of puts it on the scale of, we know that peripheral neuropathy is a toxicity. We know that hair loss is a toxicity. We know radiation dermatitis is a toxicity. There are different grades of that toxicity. Not everyone has that toxicity, but that we should be trying to at least reduce the number of people who have it or the grade that people experience. And we're at the point now where we're, again, trying to prevent it from happening altogether. So it's been kind of an exciting period of time in the last decade to kind of evolve the conversation about financial toxicity. And I'm really enthused to move into the future, which is, again, trying to fix it, stop describing the problem, start fixing the problem.
So you talked directly about medical costs that cause the financial toxicity. Can you speak a little bit about some of the things I experienced as some of the indirect costs that when those medical costs and those indirect costs kind of collide, I say that's when your financial toxicity is most acute.
Absolutely. There's been a number of different ways that people will try to kind of categorize, explain, explore financial toxicity, from direct costs, meaning, your copays, the cost of your insurance to indirect costs, like, for example, travel burden, special food you may need to eat, wigs, bras, that sort of thing. But even, again, the capacity to work. So the fact that for a lot of people during their treatment, they're not able to work to their full capacity. They may have to come out of work. They may have to hire caregivers for their children. These are all really important aspects of financial toxicity that can often be far more quote unquote expensive than the cancer treatment itself. They've been really poorly captured, especially lost income from lost work. And I think it's really important when we start thinking about how do we best help people, is to get that full scope of care around the patient and their family. I'll just mention also, when we think about the spectrum of financial toxicity, there's the financial hardship, damage to your credit score, debt. There's the psychological hardship, worry about the future. And then there's the sort of cost coping measures that can lead to worse, for example, physical outcomes. So the example I'll give is that, if you can't afford your anti-nausea medications, you're on ondansetron or Zofran, that means that you might be more nauseous. And then therefore you are going to lose weight. And then therefore you may actually have to skip a chemo cycle. And so there's all these downstream effects resulting from some of even like the cost coping measures. And for many people with breast cancer, it's a pretty straightforward equation. Like, if it's a difference between them getting their supportive medication or putting food on the table for their kids, they're going to choose their kids every single time. And it can be really straightforward. And the problem, of course, is that ultimately it puts worse outcomes for them on the table, and, worse sort of side effect profiles, potentially prolonged treatment, and overall just bad outcomes.
So I experienced financial toxicity when in treatment because I lost my job. And as a result, my home fell into foreclosure. I was at risk of vehicle repossession, and I ended up in line at the food bank. But what really made me interested in trying to address this problem, because it's very tough to solve, was sitting in those treatment waiting rooms and listening to women making impossible choices, like bring their kid home from college or put their house on the market. But the most egregious choice I heard was somebody who said, I've got 3 to 6 months more of treatment ahead of me. We're going to lose everything. I'm going to stop treatment and go back to work. And that really blew me away. So you talked a little bit about the date, Dr. Zafar. What about some of the studies you've done where you've looked at improved patient outcomes? Can you share some of those findings with us?
Absolutely. My first financial toxicity study was primarily patient interviews. So we did a study of 300 people on active treatment, and I did the interviews in about 220 of them. So it was a great introduction to financial toxicity because it allowed me the time to sit with patients and their families to have these tough conversations. We went through this fairly long survey. It took 20 minutes to get through, but we also had these great side conversations. So along with the data that we found about how financial toxicity, unfortunately, is sort of, pervasive. It doesn't affect every single person, but certainly a significant minority, more than a third of patients on active treatment, and that patients are having to make sacrifices, meaning that they're using their savings, they're going into debt. What I also found was that there was this real concern from patients about bankrupting their family. So one of the questions I remember asking specifically is, are you willing to go bankrupt in order to afford your cancer care? And the differences that I found between what the patient responded and what the caregiver responded were striking. And the survey didn't capture the caregiver's response or this dynamic. But one question was, are you willing to go bankrupt? The other one is, are you willing to sell your house? And it was just heartbreaking. You had patients that were like, no, I am not willing to go bankrupt. I'm not willing to sell my house. And then the family member would be like, no, mom, we are. That's the sort of dynamic that you don't capture in a yes/no interview question, but it really highlighted for me these really impossible situations that are happening to patients and their families. And the other thing I'll highlight is just that patients with non-curable disease, metastatic disease, were having some of the hardest discussions because, you're talking about lifelong treatment for however long life is, and that just leads to cumulative burdens. From that initial research, I have done a lot of other work to looking at, what types of support can help people from food banks, for example, to even, better conversations about costs. We've talked about screening for financial toxicity and financial need, as well as health-related social risks and needs like transportation insecurity, food insecurity, and try to facilitate referrals and discussions about costs. So I think there's a lot of opportunity about even discussions had at the bedside and screening. And then sort of the later part of my work has been really about how do we improve health structures, primarily in the United States, things like how insurance is designed and delivered. Because what your conversation with the woman in the waiting room, for many people, there's not an option to leave work at all because they have to have that work for their health insurance. And that work may also be the health insurance for their family. And so it's not a question. And, specifically, for example, there's a study of women with breast cancer is that if women, this was study was not on women with breast cancer, but if they were a lot reliant on their work for their health insurance, they actually worked more hours than people who were not because they had to maintain that health insurance.
So I've been thinking about, our hospital systems and our care delivery, and why can't people get treatment after hours, after normal 9 to 5? Why can't they do it on the weekend? I mean, if somebody shows up in the ER ready to deliver a baby on Saturday night at 9 p.m., they don't say come back Monday morning at 8. And I think that would revolutionize the healthcare system and would really help to reduce financial toxicity. I want to talk, this is not on the script, but I want to talk about this as a holistic problem because how does it then affect the provider, the clinic setting when they can't collect? What really starts to happen when that person doesn't show up for the chemo share or the radiation treatment?
Yeah, it's really interesting. Just, thinking about off hours treatments. I work at MD Anderson. I have the privilege of working down here in Houston, Texas, and we recently opened up a couple of Saturday clinics.
Ah,
And I volunteered to work on Saturday to get some patients in sooner than they wouldn't be normally, or potentially have it so that they wouldn't lose, a day of work. And that's consistently what the patient said. They were like, oh, I'm so grateful that you're open on a Saturday so that I could be here, so that, for example, I could work the full Monday through Friday. I think one other way of thinking about improving access for people who are working is things like telehealth. So I'm a radiation doctor. I understand that our facilities only open Monday through Friday. We do have 7 a.m. for people who are still working all the way till, the after work hours for treatment. But when I do a consult for someone and they're in their car, they had to, they have a wage job, or I've had a consult for someone in the alleyway behind their work in a store in the mall. I'm always like, oh, I'm so glad you didn't have to take the time off of work for this. That you're taking a break, you're taking your lunch, you're seeing me in your car, so that you can have a private conversation. But then you're not going to lose a day's worth of wage here. I
yeah.
think, in addressing your specific question, though, it's funny because when we think about when people do, for example, have those affordability gaps and that leads to them missing their treatment appointment, the hospital system loses too, right? So we
Exactly,
have
right.
people who are ready and they're ready to give the radiation. The chemotherapy was on site. It was prepped and kind of ready to go. And then if the person doesn't show, it's a zero benefit for the patient, obviously, but it's also like net negative to the hospital. And that's why it's been intriguing that there's been some studies that show, for example, that things like rideshare, so for people who have affordability gap, things like rideshare can actually save money for the hospital way far more than it costs to provide, because the patient will then actually be able to come to receive their treatment. And then that treatment is a service, just like it's a billable service. And then the hospital can actually deliver the service. So it's sort of a win-win-win, meaning that the patient gets treated, the facility actually gets to provide that service and therefore bill for that service. And then, honestly, outcomes are better for everyone. So I think thinking outside of the box, especially the structure of how we provide healthcare in the United States, is so important. And just to wrap that up, when I'm looking for example, a dentist, I'm looking for a dentist that provides services on Saturday, you know, because
Mhm.
I can't take time off of my work to go get my teeth cleaned. And so when I see a dentist that's open late or that is open on Saturday, that's my preferred dentist. And again, we figured it out for our teeth. You would think that we'd be able to figure it out for the rest of us as well.
Yeah, I'm sure there's a huge cost factor there, but hospitals are open 24/7. So let's just switch to a new concept that's been talked about, the Financial Toxicity Tumor Board with the acronym FTTB. And for those of you who know me, I hate acronyms and patients don't often understand them. So please spell it out. So what is this tumor board idea for financial toxicity?
I think the concept of just gathering everyone who is motivated and activated to fix a problem in one room and being like, how can we ease some of the financial friction points within our institution is really itself is not novel, right? But it's such an encouraging idea, which is like if you have a bunch of people who actually care about an issue, you can actually start to fix the issue. Because one person is not an island, right? You need to work within the full care spectrum to think about how to galvanize change. The Financial Toxicity Tumor Board was a concept that was initially sort of published on from the Levine Cancer Institute, which is part of the Atrium system in North Carolina. And what they did was they gathered social workers, they gathered executives, they gathered people from imaging pathology, surgeons, medical oncologists, radiation oncologists, financial care activators. They basically gathered everyone who could actually fix a problem. They evaluated their status quo and they said, how do we facilitate better care for our patients? And what they were able to do is help as reported, over 1,000 patients every single year save millions of dollars. And they did this by addressing some of the most common problems that patients were having. So, for example, not being able to afford their outpatient medications or having imperfect insurance for the care that they needed. And I think thinking about that full scope, the everything that can happen to a patient and how to actually, again, ease down those financial friction points is really how they did that. They just published a 5-year follow-up recently, again, just talking about the development of the program over time and then sort of their long-term endpoints. Classically, and you know this from running your own nonprofit, it can be challenging to show that what you gave to a person, either like unrestricted cash funds or the financial assistance for a medication, how it helped them in the long run, because it should be obvious that it helped them. But sometimes we're bad at that second part of it, which is capturing how it helped them and whether or not that help was durable. And that next step is really important when thinking about sustainability and funding for some of these projects that really do provide meaningful assistance to patients in need.
So I want to just jump in for all the advocates who will be listening to this and sharing some of this information. When I was diagnosed, finished treatment, I was prescribed an aromatase inhibitor, which was on brand at $300 a month, and there was no way I could take it. Fortunately, there was a clinical trial. So I did the clinical trial. But the other thing I did is I had this was 2005, $3,600 in copays. I had no job and no money. Remember, my house was going to go into foreclosure. It wasn't foreclosure. So I negotiated a payment plan with the hospital. And I think that's really an action that a patient can take. If he or she realizes that this nut that they're looking at in terms of their medical costs, perhaps lost income, indirect costs is going to cost X, and they go to the financial services office at the clinic, they will generally work with you as long as you make that payment as legally agreed upon. So that's one solution. So advocates, like there's so many of us in the breast space. What do you think we can do to advocate for this and help take some steps to change the outcomes of financial toxicity or perhaps just the screening processes?
I think there's a lot of ways that advocates can get involved, and there's a full spectrum of ways of getting involved within either their community, online, within patients, and their discussions within specific, for example, Facebook groups or on Twitter or X, but also within their institutions, within their state, and within the nation. And I think thinking about that full spectrum, that means sharing resources that you've acquired, or spreading the word about what's available, like, for example, direct assistance from the Pink Fund, to advocating within their center for things that are very practical, like, for example, free parking, to within their state, thinking about what are the actual state policies that can make an impact. So advocating for Medicaid expansion within their state, or for better accountability for prior authorization, something that specifically disproportionately affects people with breast cancer, with some of these expensive oral agents that people are on. Or at the national level, thinking about how do we get involved with breast cancer advocacy at the national level to, for example, eliminate the 2-year waiting period
Yeah.
for health insurance for people who have metastatic disease. It's a huge burden, and it leaves many women and men with metastatic disease stuck, having to really suffer to wait it out to actually receive disability benefits and then Medicare, Medicaid.
And let's talk about that 5-month waiting period once you're approved for SSDI benefits, where you can show no working income. Most
Absolutely.
people cannot wait for that amount of time. I mean, we at Pink Fund have a small fund that helps with that if you're metastatic, and we can pay some of those bills up to 6 months, but it's an impossible situation. And I know that many of us lobby in Washington to get some of these things changed. So getting involved in legislative affairs, as you mentioned, at the state or federal level is great.
And it doesn't have to be just focused on breast cancer, because, to be
Mm-mm.
honest, even something like work requirements for Medicaid is a huge burden, because the amount of paperwork that you need to have when dealing with, for example, a cancer diagnosis, to show that you can't work to maintain your health insurance can be insurmountable for people. It's just one more burden that can sort of break the metaphorical camel's back. And the idea that you would be decertified from your Medicaid because you couldn't show that you would work when you have something like metastatic disease is, it's bananas.
Mm-hmm. Very, very stressful. I know that in my situation, I had a life insurance policy out on my kids, or just in case something happened to me, because I'd been through this divorce. And I do remember thinking that my children might be better off, at least having a roof over their head than a mother. And that messed with my mind a bit. I want to go back to the panel that we were on in Chicago. And Christopher Booth talks about the buckets. I don't know if you recall that. Can you talk about those? There were 4 buckets, as I recall.
I have heard Chris Booth speak a number of different times. I think there's only 3, but please
Okay.
correct me if I'm wrong. Chris, if you're out there, let us know. But this concept that there's opportunities for improving care from even some of the more fundamental, like, how do we design research and what questions are we asking for research? And so I'll sort of pivot from that to actually the concept of, within research, we're often trying to find the maximum tolerated dose, in kind of phase 1, phase 2, maximum tolerated dose. And then phase 2, phase 3, is that a maximum tolerated dose, effective at, for example, treating breast cancer, prolonging survival for women and men with breast cancer, right? And I think we need to think about, well, really, should we be studying maximum effective dose? Maybe we should be actually evaluating minimal effective dose, right? Which is what has the best side effect profile, lower costs, but also is more tolerable and sustainable for people. And that's actually an initiative being actually piloted by advocates right now with the Right Dose initiative.
Right.
But also, are the things that we're studying in our clinical trials actually meaningful to people? I think everyone understands that they want to live longer. That's a very common goal, right? But sometimes we're actually evaluating drugs and whether or not they're effective based on an imaging study. So whether or not the image went up or down, whether or not a lab went up or down, and not actually like quality of life, quantity of life, functional preserved life, not patient-centered metrics. And I think that's the general gist of Dr. Booth's talk, is that we need to really be thinking about how research is being conducted, how it's being powered, and what are the endpoints that actually matter to patients. Because everyone wants to live longer, but no one wants to live a long time, in, bed bound with no quality of life. And so trying to find that balance of what are the best ways of combating disease, but also preserving time and quality of life and finances. How do we actually, mitigate things like time toxicity, financial toxicity?
Right. And I think those two really kind of go together like hand in glove. When we were talking earlier, like time toxicity is I have to take a day off work with no pay to go get my treatment. And there again, that would require a really revolutionary system change. But if we don't begin to think differently, things aren't going to get any better. So, um, so the Pink Fund is one of the national associate nonprofits that provides financial assistance, and so do others. And I just want to mention just a few. Komen has a patient program, as Living Beyond Breast Cancer does. And those are all for primarily, I believe, non-medical expenses, but there are a number that provide copays. So Patient Advocate Foundation, Patient Access Network Foundation, HealthWell, et cetera. And it's important for patients to really, when they sit down and ask, I think they should be asking for a financial navigator. I mean, they don't know to ask, but that's where we can start to educate. That's when those things can be discussed. So what's out there in the clinical system, what's out there in the nonprofit system, what's out there in the government system that can help me bridge this temporary challenge in my life.
Absolutely. And again, that whole idea that patients don't know what to ask is where patient advocates can really step in, which is within your community, within your communities online, say, hey, I had Medicare, so I wasn't able to get foundation help for this, but I was able to, get this. Or, hey, I found that this organization was really helpful to help me get to this facility because I was participating in a clinical trial. Or, hey, if you do participate in a clinical trial, most clinical trials will actually help offset your travel costs. And they won't tell you that up front, but they will tell you that afterwards. And it might have made the difference between you enrolling in the clinical trial or not. And so I think there's so many.
I have to jump in on the clinical trial thing though, because some of them are reimbursement and many people don't have, like when I went through my situation, I didn't have a credit card and I didn't have a debit card because I didn't have any money. So I couldn't front a plane ticket or a hotel stay. And I think that is the challenge for many people who really could participate in a trial and need to be in a trial and could help improve the trial outcomes because they're from a diverse population, don't have the financial resources to front those expenses.
Yes, and almost all clinical trials, it's reimbursement for expensive, not upfront, costs, not upfront, disbursement of funds to help with travel, and it's a real barrier. I think that's also, again, you think about an advocacy priority, advocating at the pharmacy level. A lot of these clinical trials are funded by pharmaceutical companies, and so maybe that's something that they can start building into their clinical trial design. These upfront payments for travel to offset those costs. I think, some of the other really common sense things, like, for example, there's ways of, like you had mentioned previously, payment plans within your institution, right? But once you put something on a credit card, it's no longer medical debt. It's actually it's just credit card debt. And so it can't be on a payment plan from the institution. It also cannot be forgiven. If your institution is a non-for-profit, they often can forgive debt if you're under a certain income level, but it can't be forgiven if it's on a credit card. It's no longer medical debts. So kind of some of those nuts and bolts is really important to be sharing within the community.
So if you do find yourself with significant medical debt on a credit card, there's a national organization called Green Path Financial that will negotiate with your creditor payments that you can actually afford to make, and sometimes can eliminate that interest, which is what can kill you over the long term.
Yes, and that's actually, a lot of people don't, when they think about credit card debt or any kind of debt, the debt is packaged and sold on a daily basis in the United States. It's pooled, it's sold to other companies that then try to collect on it for pennies on the dollar. And eventually, you really can buy debt at a very low cost. You can buy it at scale, which is one of the things that RIP Medical Debt recently renamed Eliminate Medical Debt. But it's at the point where debt, unfortunately, is its own business in the United States, which is why I think, again, national solutions are better. Advocating for national solutions are also one of the potential ways of forward thinking about the problem of affordability in healthcare.
So I did experience creditors coming after me, and I saw a credit attorney, and he said to me that this thing where you have collections coming after you and you agree to settle with the collection company, they sell off the remaining debt to another collection company, and they come after you. And he said it's kind of like cancer coming back. You never really get rid of it. And they won't negotiate with you and provide you with something in writing that the debt is paid, done, forgiven, move on. But many patients are stuck. And right now, one of the other challenges I think on financial toxicity that I'm seeing a little bit of is having to make that copay before you get treatment. Are you seeing that?
I think that what I'm increasingly saying, I'll be honest, is high deductible plans. So that's where before it's like not even a copay thing, is you have to meet your deductible. So that means I saw recently, someone whose deductible was at $10,000. So that means they actually have to pay out $10,000 before their insurance kind of kicks in at all.
Mm-hmm.
And that is increasingly what I've seen kind of in the Post-Affordable Care Act world, which is, there was a lot of positive movements in terms of, getting people insured, but the quality of the health insurance that they have available for them is actually going down. So I think, again, just points to that concept of how health insurance is acquired and delivered in the United States, and the quality of the health insurance that's available is quite variable. And unfortunately, these costs are being sort of pushed onto patients in many sneaky ways that weren't previously a problem for people who, for example, might have been treated 20 years ago versus being treated now. And that's, again, you're very obviously involved in the advocacy space. And so I'm sure you've seen these things evolve over time. And it's sort of horrifying one way or the other. They're getting them, squeezing blood from a stone for these costs.
So can you give an example of a sneaky way that you alluded to?
I think that
we all need to be watching out for the sneaky ways.
Yeah. The sneakiest way that I've seen is actually in narrow networks. And so it's not something that you necessarily even know until you have the health insurance.
Right.
Which is because health insurance companies are constantly renegotiating their contracts with service providers. You may be even on the same health insurance through your work, and the new year comes and suddenly you can't see your provider because the network changed. So you have an established care plan, you have providers that you trust. They've been taking care of you the last 5 years, and then suddenly you can't see them before because the network changed. That's actually the sneakiest in my mind.
And so what concerns me about that is we're in this open enrollment period. We're moving into this now, right? So how would you as a consumer really know what you might be needing in the next calendar year, right? Or some of the formularies are no longer on that insurance plan, and then you have to change insurance plans in the middle of treatment and get new doctors. And
Yeah. So one thing that I think patients don't often know is that even when your provider is out of network, there can be still an option. So there's things that are called basically negotiated single case agreements between a health insurance company and an institution where this person is now out of network, but they have an established treatment plan here, and so they can get these single case agreements that actually allow you to continue care, and advocating for those, and understanding they're a possibility, and not just saying, okay, I guess I have to change plans now, or I have to change providers now. I think that's a really it's an important piece of information for people to know that there may be a way for them to keep with their provider. And again, thinking about I know we had talked about even just thinking about within the capacity within each institution is outside of just your team, right? So the support services available within institutions are quite different, right? So if you have an established team, but also you're receiving supportive care within that group, not just palliative care, but also, you know, the support groups, the peer-to-peer, the financial counseling, those things are really tailored to the institution and the resources. And so being able to stay in one institution is really important.
So, to whom would you address that question about the change in insurance or the drugs that you need to be taking within the clinical setting? Who would that person be? Who should you
So,
ask?
yeah, asking for a financial counselor can be very helpful, but then you can also advocate within whoever is providing your health insurance. So, for example, within your workplace,
Mhm.
because I don't think the people negotiating the contracts for this health insurance actually necessarily know the specific barriers that are happening within their employees. And so, getting your actual company involved as well, it can be very helpful. So, kind of all guns blazing, right, when thinking about how to best address these issues.
Okay, so I want to go to top 3 tips for a patient in treatment for cancer around financial toxicity, and then go to top 3 tips for advocates to really perhaps change how it plays out. What can we do? We talked about it, but I just want to distill it into the top 3.
So the first tip for patients to just know what your treatment plan entails. And so for many people, when they're diagnosed, there's going to be some period of workup. You're going to meet all your specialists involved with it, but then you'll have kind of an outline in general of what your plan is. And thinking about that big picture is really important for people. So, for example, I know I'm going to need 4 months of chemotherapy, and then there's going to be a month gap, and then I'm going to have surgery, and then there's going to be a month gap, and then I'm going to need radiation, and typically that radiation is going to take about a month. So having that idea up front can be very helpful for you for planning purposes to know when you can, for example, work, when you can't work, how much time you're going to have out of work, if you should be asking for about short-term disability or long-term disability. Nothing ever goes according to exactly to plan, right? But having a rough outline and kind of knowing so that you can start preparing, I think can be really useful in terms of thinking about financial toxicity and specifically things like travel and work planning. Number 2 is just to know what your health insurance pays for and the quality of your health insurance. And if you have the opportunity to change insurance somewhere in your treatment course, to think about what is the best insurance plan for you. So, for example, if you're in a high deductible health insurance plan, is there an opportunity for you to change your health insurance plan at the next election cycle? Or is there a way of, optimizing your outcomes just based on the type of insurance that you have? Is there an opportunity for you to transition to a different type of health insurance, either for example, your partner's workplace or one of the government plans? Is there a better ACA marketplace plan for you to pivot to? And then the third one is to just think about who you have within your this is maybe less of an affordability concern, but who's your resources that you can rely on to help get you through treatment? Because I think that many people are sort of thinking about like how to get through this on their own, like a warrior mentality. But virtually everyone has some sort of friends help that can actually, rally resources, but their friends don't know what to do. They just, they don't know what help
Yeah.
would be meaningful for you. And I think, if you can give them tasks, I really need you to come over every Friday and do the laundry. I really need you to provide me, food, lunch for my kids on Tuesdays. People love that kind of task. And if you have it within your capacity to actually think about that sort of thing and plan for the future, and to know, okay, I don't need to worry about Saturday afternoons because that's when my sister comes and takes the kids so I can have a relaxing day. That is a huge thing to kind of think forward for. Like, make a wish list of these are all the things that would be great if you could do, because your friends and family want to help, but they just don't know how to help.
Right.
and given a vacuum, you will just get 5 casseroles and not your laundry done.
Yeah, I got a lot of lasagna.
Mhm.
Um, Dr. Susan Love used to say, if you can't advocate for yourself, find your best badass take no prisoners friend, right, to be your advocate. And I think in the space of financial toxicity, patients are often, as we spoke earlier, concerned that if they express a concern, they will not get the best treatment. And in fact, anecdotally, a patient here in the Detroit area was sharing with her physician that she was concerned about lost income. And he said to her, we'll give you a lower dose of chemo. And that caused her a lot of anxiety. So how do you, is there any research on that? Is there anything that's shown that they get a lower dose and their outcomes aren't as good?
Yeah, it's interesting. Again, this concept of the right sizing. I think, classically within medicine, we've called it de-escalation, lower dose, finding the tolerable dose. And it starts with this whole idea of maximum tolerated dose, not minimum effective dose. Whereas
Mhm.
we know that actually a lot of the trials show that even the Olympians enrolled on some of these randomized controlled trials, see, there's the sort of the best of the best patient, they're marathon running, people. Even in a lot of trials, there might have been 70% of the population that needed a dose reduction. So even though we're trying to get you onto this, like, dose that was studied in the trial, even on the trial, 70% of people didn't actually tolerate that dose. So I think we need to have better language about describing finding the right dose for people, or, right sizing the dose. But absolutely, patients have definitely voiced the idea that they were worried about bringing up costs with their provider because they were worried about having some sort of compromised care. And I think that's why, for me as a provider, I try to provide patients with the opportunity to discuss their costs from the outgo. So, thinking about screening for financial toxicity, or bringing up with every single patient this concept that things can be expensive. I want to know if you're ever having problems affording your care. Because certainly, I think, from my own experience, when my husband and I were going through financial toxicity, we didn't realize that it was something that we could talk to our provider about, and we were really ashamed about our costs.
Mhm.
So I think normalizing the conversation and saying, hey, this is something that a lot of people experience. You may not experience it, but if you ever do have a problem with it, I want to know. Because sometimes it's just a matter of changing from Zofran to Compazine, right? They're both anti-nausea medications. This one, might be more expensive. This one might be cheaper. If they both work, great, use the cheaper one. And I think that patients don't necessarily understand when you do a dose reduction that it may not actually make a difference. And in fact, there's a whole arm of research now trying to, again, right size the dose. So if there's a way of giving 5 treatments of the radiation instead of 20, 5 treatments of radiation, get the 5. If it's not going to make a difference in terms of your actual outcomes and it's more convenience, 100% do less. And so that's sort of where we are in medicine from a de-escalation or right sizing. And then I think the conversation needs to be better had with providers about, hey, this is okay. It's not going to change your outcomes in a negative way, but it will make things more convenient.
So I think a lot about the fact that, when you go to the doctor, they have these standardized questions. Like, particularly, I'm older, so they ask me, "Have I fallen?" No. And I think it needs to be addressed in such a way as that we ask everybody these questions about financial toxicity. It's just like give them a list of your prescription drugs, all the standard stuff we do, because we don't want to assume anything. And you know what they say about assuming.
Yeah.
So
It
back to
makes an
what,
ass out of you and me.
yes, an ass out of you and an ass out of me. So going back to what advocates can do, top 3 tips, because you said this is what the patient can do while in treatment, and let's what advocates can do specifically.
Yeah, I think, honestly, getting involved with national societies can be very helpful. I would say that is a priority for number one. So thinking about what you have the bandwidth to do within your own life, right? You don't want to overextend yourself. But if there's, a peer group within your institution, within your treatment facility. If there's a national group or a state group, I would certainly say, explore your options and, get involved in organized fashion, right? I would say for the second one from advocates is to really think about on the national scale, how you can start pushing forward these issues within your communities, your family, within whatever capacity you have within your Facebook group, because thinking about the affordability gaps and how they're only unfortunately getting worse, I think maybe there's just a messaging problem. I think having that voice as a patient gives you an important mandate, right, to speak for others in terms of this is what happened to me, this is what's happening to others. I need to come forward and as much as you feel comfortable, share your story about it. I would say in the kind of third line, it's making sure that within your capacity that the community that you're building is sort of moving forward in a positive fashion, I guess, if that makes sense. We all want to make sure that we're sharing stories that are actually moving the needle forward. We need therapy too, right? Yeah, I need someone that I can just complain to, right? 100%. But that, things like misinformation are being combated, that we're actually, making sure that we're couching things in, this is what happened to me. Other people might have different experiences. So thinking about building a dynamic and forward-thinking community is really important. I'm not sure if those were three distinct things. It's all kind of the same thing.
Well, I think a little bit you're alluding to the fact of being authentic and vulnerable within a safe community. Like you said, some online chat groups, things that they're not afraid. The other advocates are not afraid of what you might say, but other people in your lives are, because it gives them anxiety when not about your physical health, but your financial health. I don't know if I want to ask one question. What's next for you on the research in financial toxicity, if you're able to share what you're studying now?
Absolutely. So one thing that I really started, and I think it came up a couple times here, was this concept of low quality health insurance, high quality health insurance, what insurance pays for, and how some insurance companies put up more barriers to receiving optimal care. So I'm really interested in looking at this, particularly for the populations that really do need durable, high quality care. So for example, the metastatic breast cancer population. So people who really need high quality care that is stable through time, because as you know, people with metastatic breast cancer are living longer, more fulfilling lives, but despite that, often need ongoing treatment. And so stable health insurance really matters. So looking at the gaps in care, the specific like narrow networks, prior authorization, and all of these things that actually contribute to insurance quality is what I'm really interested in exploring next.
Well, Dr. Chino, thank you so much for your time. We look forward to actually seeing this ourselves to see if we all made sense. And as you know, I'm like one of your biggest fans. So keep up the great work, and I look forward to seeing you in San Antonio.
Absolutely. And I really just appreciate the opportunity to share with this. I want to thank the organizers of this conversation, and hopefully can get some benefit to a couple more people and get them involved.
Thank you.